Good evening, Endo Summit Live, and welcome to this very exciting webinar on the hip and hip pain, pelvic pain, and endometriosis. We have some of the nation's top professionals joining us today, and we are really pleased to have everyone here. We're going to start with you, Dr. Sandra. Do you want to introduce yourself to everybody?
Sure, be glad to. Hi, everyone. My name is Dr. Sandra Restaino. I'm a pelvic pain specialist here at West Palm at Pelvic Rehabilitation Medicine. And as a physiatrist, I specialize in treating the muscles and nerves and joints of the pelvis, including the hips.
Fabulous. We also have, it's funny, we're in a Zoom order. I always feel like the Brady Bunch. Over on my right, we are joined for the very first time by Ginger Garner, a pelvic physical therapist who is so much more than just a physical therapist. Ginger, can you introduce yourself to everyone?
Sure. Yeah, I'm Ginger Garner. I have my doctorate in physical therapy and a few other things. Grew up as a sports medicine PT and then just translated into pelvic PT and all the things that I do now. But I'm in Greensboro, North Carolina. I own and operate Garner Pelvic Health and a continuing education organization and everything about the pelvic girdle, actually, which goes from the voice to the pelvic floor. So I kind of take a 3 diaphragm approach to treating all things hip related.
Yeah, so next year I have my eye on you about the voice. So we could do the voice, but Endo Summit style. So I would also like to welcome Dr. Marjorie. Dr. Marjorie, do you want to introduce yourself to everybody?
Sure. Hi, everyone. My name is Dr. Marjorie May Mamsaang. I work with Dr. Sandra Sandu at Pelvic Rehabilitation Medicine. I'm a physiatrist as well, also fellowship trained in sports medicine, and I teach yoga.
Fabulous. And rounding out our faculty for this evening is Amy Stein. Amy, do you want to introduce yourself?
Sure. I'm Amy Stein. And by the way, if anyone hasn't heard Ginger sing, you need to hear her sing. It's quite remarkable. So maybe at the end or in the middle, Sally, maybe.
Does this mean when I bring her to do the voice section next year that we'll have karaoke night instead of a pool party?
Karaoke night is awesome,
I'm
but
game.
you don't want to hear me sing. I'll just dance for you, Ginger.
Oh
Well,
my
they tried
gosh.
to talk me into silent disco, so I always want to do that.
Yeah, that's fun.
Yeah.
Yes, I'm Amy Stein from Beyond Basics Physical Therapy in New York City. I'm the owner and founder and the author of Heal Pelvic Pain and Beating Endo, How to Reclaim Your Life from Endometriosis. And I'm so excited to be here. Thank you for having me.
Right. And we are excited to have everybody who will also be presenting at the Endometriosis Summit. Dr. Marjorie, we're going to veer from our normal pattern and do a little exercise today because you have a huge background in that.
Sounds good. I'm going to just move my camera so we can see a little bit better. So this is, okay. So these are just some hip opening exercises, yoga based, to open up the hip joint, but also relax the muscles in and around the pelvis. So including anterior hip, iliopsoas, and also glutes piriformis. So the easiest thing I like to do is, so just opening up the range of motion in the hip joint. So you can start with one side, internally rotating, and then going externally rotating. Yes, Sally.
I still have my filter on.
And then, of course, doing the same thing on the other side. And then you can do both at the same time, windshield wiping your legs. I love to start a class with this. Then now, so you're externally rotating one side, internally rotating the other side. You could do this sitting up like me. It feels really good if you're laying down too. And then if you pause on one side, so my left knee is down, it's internally rotated, and then you bring your right ankle over your left knee. Now you're kind of going towards that barrier of interband. So this feels extra nice when you're doing it supine, laying down. And of course, do the same thing on the other side. That's the easiest thing. And of course, with anything that you do, let your pain be your guide. So don't overdo it. If anything feels too intense, pull back a little bit. The
I have a
next one.
question. I learned that one laying down. Do you do that one
Yes.
sitting up?
Yes, I did it sitting up just so you can hear me talk, and I can see myself doing it, but it's the best to actually do it laying down.
And would you have people do that in the morning, or would you? I think if you work from home, you should get up about 3 times a day and get your hips moving. What does everybody else think?
I agree.
Excellent. Excellent. All right. Thank you for that fabulous exercise, and props for the yellow sweatpants.
Yeah, I tried to be
Props.
colors.
Props. Okay, so let's talk about pain in the hip. I want to just share that we ran a post on hip, and it is our most liked post with over 2,000 shares. And in some ways that scares me that so many out there with endometriosis are going through hip pain. So I'm going to ask Dr. Sandra first. Somebody comes to you and they have sort of hip pain and groin pain. How do you eval? And then we'll shift it to the PTs to hear how it might be a little different.
So we always start with taking a good detailed history. And what we're simply looking for is that pain source generator. What is causing that hip groin pain? Things that we're looking for: description of pain. When did it start? Did it occur after an injury? Basically their background, if they have any autoimmune conditions that may lead to maybe arthritis in the hip. Do they have any hypermobility? Some may have Ehlers-Danlos syndrome, which can lead to laxity of the ligaments in the hips and the pelvis. That can lead to hip disorder and pain there as well. And then in addition to that detailed physical examination, or that detailed history that we're doing, we're also do a detailed physical examination to the patient, where we're examining not just the hip, but also the surrounding structures that can contribute to hip pain, like the low back, spine, abdomen as well, the pelvis, the pubic bone area, all the muscles that attach to the area, that can all affect and lead to the hip. So it's kind of like a quick overall overview of how we kind of look at hip pain when a patient presents with hip pain. I'm just getting good detailed history in the physical examination, looking for that pain source generator.
Yes, excellent. Okay, so Ginger, somebody comes to you, I think a lot of times doctors write script and they write like hip pain, eval, and treat, and like then the PT really has to go to town. Can you talk a little bit about what you're looking for in an evaluation? I mean, reasonably in an evaluation, because PTs, it could take us an hour to answer.
I know. It does vary. I have people travel out of state regularly for, higher level hip issues. And so I ended up going through an extended assessment with them, which may include using rehab ultrasound imaging to identify, is it glute med versus glute min? What's the iliacus doing? What's the psoas doing? What's the obturator internus doing? What does the lateral abdominal wall look like? And the ratios and values there. But I also take a little bit different approach. My book that I co-edited with Joe Tata 2 years ago now, because time flies, Integrative and Lifestyle Medicine and PT, I will look at those aspects of how I can integrate those pieces into treatment, but as well as yoga too. But in terms of what else I might assess, it's a hands-on physical assessment in addition to the imaging, but I will look at how someone is able to manage that intra-abdominal pressure. So it'll be easy I'll do things like have them vocalize, which may sound like a downstream effect or ripple effect, and it really is, because if they're not able to even say something like or their name, you can immediately see how that negatively impacts things downstream, the pelvic floor and the surrounding structures, the obturator internus, and things that may be impacted, so that their neuromuscular patterning can get a little off. So I'm looking at those higher level patterns that honestly, when I look at I end up shaking, what shakes out for treatment in the end, it often comes down to kind of pulling the plug and resetting patterns, plugging them back in and getting people to be more intentional about how they move. But also looking for instances of, like, if they do bring other imaging in, looking for evidence of microinstability, like Dr. Sandra, like you said, with what is it, whether it may be borderline dysplasia or other issues where maybe the acetabulum isn't centered, or the femoral head is not centered inside the acetabulum, and they can feel that, and you can see that in gait and when they're walking, as well as when you're doing different things with imaging. So there's a lot of different aspects to look at. And then outside in the lifestyle medicine realm, it may be simply, well, are they perimenopausal? Are they going through menopause? What's happening with hormone management? Because then that can increase issues with the pelvic floor, and then how aches and pains may manifest themselves. For example, if they have a lab like high sensitivity CRP that's elevated, then they may be walking around with that elevated inflammation all the time, which may give them more than just hip pain. It could be radiating out into other areas. And then finally, just differentially diagnosing things like SI joint dysfunction and seeing, where exactly is the pain coming from? Is it truly a pelvic issue, as in pelvic floor PT, or is it really coming out of the hip or other related areas?
Very, very good. So, Amy, I'm wondering, how does the pelvic floor interact with the hip?
That's a great question. I would say, by the way, just to add on to the amazing things that you all have said, we also look at function of like a squat and how they sit in a chair and how they go from sit to stand. So also important to look at that, and knee function, and all the way down to the foot, all the way up to the head, and the vocal system for sure, the interabdominal pressure. And then how it relates to the pelvic floor. So I actually worked with, I think it was the one and only study, maybe that, I'm sure there's more now, but Dr. Deborah Cody, when she did a study with Struve and Coleman on the hip and the pelvic floor. And they basically found that some hip dysfunction, specifically more like impingement, labral tear, can be a contributor to pelvic floor because of the close connection of the pelvic floor to the hip. So the obturator internus, as Ginger mentioned, is a big contributor because it connects, it's part of the pelvic floor, and it connects to the hip, and it's a hip rotator. So if there's dysfunction or decreased mobility in the hip, it can contribute to pelvic floor issues as well. So I think in their study, they found some urgency, frequency, as well as some pain with their patients. And sometimes hip surgery did help, but sometimes it didn't. You really have to differentially diagnose the patient with assessing the pelvic floor versus the hip, using our wonderful physiatrists to figure out, is there a nerve that's irritated, and doing a nerve block in that area.
Those are the next questions.
But yeah, it's connected. And one of the symptoms that I've seen more frequently, and this could be just clinically, is more urinary symptoms. And I think it's how the obturator connects to the hip and connects to the pelvic floor area and any nerves that run through there. But
yeah, I definitely see the obturator and the bladder going together. And also because that bladder has such a sensory driver of the system, the bladder will spasm the muscle and then hurt the hip. So I'm not 100% sure this is going to work, but I'm going to try to get this to work. Because Ginger brought up something very, very important, and I wanted to show exactly what she was talking about the diaphragm and the hip. I'll point the cursor if you want to talk a little bit more about that, Ginger.
Yeah, sure. This is awesome that you have the visual. Thank you, Sally, for pulling that up. So there are several different ways in which we can look at connections, and one of those is muscular. There's also a neural connection and a fascial connection. But if you look at the dome of the diaphragm, which runs from about T8 to L2, it should be nice and high. And that is one of the things that I do measure with imaging, is to look at that angle, or apposition as we call it, in the diaphragm. And then if you look at the several openings in the diaphragm, near the spine, near the central tendon in the back, you see the lovely psoas, which can be ever so snarky. I have several videos on the snarky psoas and a few blogs. As it comes off of those vertebrae and the lumbar vertebrae, crossing through the abdominal cavity and across the front of the labrum, which it loves to compress when it's too tight, which is oftentimes why I will avoid stretching, particularly of the psoas or the iliacus. And then the iliacus coming in to blend with the psoas major and minor, and then and over. That's important from a muscular perspective because it joins those three diaphragms, connects the voice to the pelvic floor, and there's also a fascial connection as well with the deep front line of the fascia, which goes from the orofacial area through the respiratory diaphragm to the psoas, like you can see here in the iliacus, and into the pelvic floor.
Yes, that is amazing. I thought we would show that a little to our docs. I wonder how might diaphragmatic endometriosis affect that chain that Ginger is discussing?
So I always explain to patients that so that everything is connected, in that the pelvic floor, abdominal muscles, lumbar paraspinals, and even the glutes, all of that is kind of like the foundations of a house, with the pelvic floor being the floor, the lumbar paraspinals and the abdominal muscles being the wall. And then up top is the diaphragm, that's the roof. And if your diaphragm is constricted because you have endometriosis and pain in your chest wall, in your lung, in your peritoneal, in your cavity, in your lung cavity, then also your pelvic floor is not moving great. So there's that connection there. So that can cause pelvic floor hypertonicity, but also pelvic floor dysfunction, and any of those symptoms: bowel, bladder dysfunction, sexual dysfunction.
Excellent. Now, before we start to get into the neural anatomy, which my physiatrists are going to love, I just wanted to take a moment because Amy has mentioned. Amy, here you can see a lot of our viewers might not have a visual of what this obturator internus looks at. Do you want to just describe the muscle a little bit from here?
Sure. Yeah. So it connects obviously to the hip bone there. Could I use my cursor or no? Can you
No,
see?
I'll just try to follow along.
Okay. So connects from the hip and then goes, it almost makes like a cup and connects to the pelvis. So like when you palpate it, it's almost like you're palpating a cup that connects to the hip. And there's a nerve that runs through there. There's there's tendons. So the arcus tendineus connects to there, which is a thick tendon. And then, yeah, and then it connects to the pubic bone in the front. It's pretty wide, like a wide, a fan, almost like a fan, like sort of.
So, Dr. Marjorie, what's running between these two ligaments that might be of a whole lot of importance to you?
I didn't say it because I wasn't allowed.
I know, we're waiting. We got to bring them on. I'm going to look for a photo for her while she's talking.
It starts with the letter P.
It starts with the letter P. Oh, I do have a photo. Wait,
Oh,
don't
good.
yet. I never get to bring up my fun. By the way, if anybody is a PT out there or a professional and they love these illustrations, they all come from the GFAM with Pelvic Guru, and it's really a fabulous thing to have to show patients. So Dr. Marjorie, you're on. This is just a piece, a very small piece of the posterior neural anatomy. Do you want to talk a little bit about some of these nerves?
Yeah, sure. So the big P nerve that runs through the obturator internus is the pudendal nerve. The pudendal nerve gives sensation from the genitalia all the way down to the rectum, helps to give function to the pelvic floor muscles, and then for male and female also helps with sexual function. So when you have any hip range of motion limitation, the way I explain it is the obturator internus has to work harder, compensate for that lack of range of motion. So then it becomes spastic. And then because it's spastic, it's compressing over the nerve, and over time it starts to irritate it. You build up all this neurogenic inflammation, then you get dysfunction in any of those areas. You can have pain in any of those areas in that skin distribution, and you can have some sexual dysfunction too. And then more laterally, you also have the posterior cutaneous nerve of the thigh. So there's a lot of crosstalk. So when there is one nerve that is inflamed, it is very easy for the crosstalk to happen and the nerve inflammation to spread. So the posterior cutaneous nerve of the thigh can also get inflamed. Every now and then, patients who have an irritated pudendal nerve do complain of that pain along that ischial tuberosity or the back of the thigh. But most often, if your pudendal nerve is irritated, posterior cutaneous nerve of the thigh is also irritated.
I've had patients that I've shared with Dr. Ahmed that their pudendal nerve is so fired up they could never handle like an injection into them, and they get the injections into the posterior cutaneous nerve to sort of calm everything down. Is that something that you guys find kind of common in your practice?
Yes, very much so. In fact, anytime I treat the pudendal nerve, I treat posterior cutaneous nerve as well. Always treat both.
And do you ever mix in sending patients off for a bladder installation about these nerves to get them to calm down a little bit?
I personally do not, even if I have a high suspicion of true IC. The reason why is because I feel like the results are very mixed, and it's 50-50 hit or miss. And a lot of the times when it's a miss, it doesn't just not work, it doesn't help them, but it flares their symptoms up. And speaking also to urologists that perform bladder installations for a while, a lot of them tend to not do it anymore just because it's so hit or miss. So I personally don't. I tend to really, like, even if I think true IC, optimize the pelvis. So really more of a multimodal approach, including pelvic floor PT.
It's interesting. I got sucked into this patient board with AUA, with the Urology Association. And we sat through a whole thing presenting that like the true IC with the glomerations are now being traced back to biofilm infections in like something like 90% of cases. So not necessarily the pain generating IC where you don't have the glomerations, but the other kind. And so also at the summit, somebody else who's lurking in the audience, doesn't want to come up tonight, is going to present totally different research on why you would do the bladder and the pudendal nerve together. And it'll be interesting to have you guys there and discuss that with everybody. So let's talk about Dr. Sandra, what do you do imaging? Do you send patients off for imaging? Do you do PT first? How do you approach somebody with some hip pain?
So as we know, hip is connected to the pelvic floor. So we always try to address the pelvic floor dysfunction first. The reason being, I've had some patients where previously to seeing us, they have gone down the route of getting imaging of the hip. They've seen hip ortho. They may have gotten surgery to repair maybe a labral tear or a hip impingement, but then they continue with pain afterwards. So our goal is to help treat that pelvic floor to make sure it's nice and relaxed, because any kind of surgery can flare it up, including any kind of hip repair. So we want to optimize the pelvic floor first. So that's always the goal. And we utilize a multimodal treatment protocol to help treat the muscles and nerves of the pelvis with the goals to help reset the nerves and relax the muscles back to its normal tone. And we utilize that multimodal approach by having patients do weekly set of injections, where they typically come once a week for 6 weeks. We're performing 2 things, hydrodissection, peripheral nerve block to decrease that neurogenic inflammation of the nerves of the pelvis. And we also perform trigger point injections of the levator ani muscles to help relax and decrease those trigger points that are created by the spasms of those muscles. So by doing that, in addition to that, we also do suppositories to help break that spasticity cycle. The suppositories, we do a combo of muscle relaxers and some nerve pain medication that they do weekly. And it takes about a 12-week process because it takes time for the nerves to heal. So we always teach patients that it's not a quick fix. You got to give it time for the muscles and nerves to heal. The nerve usually takes a little bit longer. And then in combination to that, we also treat the central aspect of pain. Typically over time, the signal that goes from the pelvis to the brain becomes upregulated. So we have to calm that too. So that way patients diminish pain flares going forward. So typically we have patients on an oral neuromodulator. Examples include Lyrica, gabapentin, Cymbalta, or amitriptyline or triptyline. Just depends on what they've tried. Again, they're not on it long term. It takes about 8 to 12 weeks to help decrease that central component of pain, that central sensitization. And then we also always have our patients work with pelvic floor therapists at the same time that we're doing that multimodal approach. You guys are key players, so we appreciate you so much. You guys do so much hard work with the goal to help basically relax. We always say that the pelvic floor should be nice and relaxed, and it contracts and relaxes to help facilitate bowel, bladder, and sexual function. But in our case, the patient's pelvic floors are typically very contracted and spastic. So the goal is to help relax it. That's where the suppositories come in. And the PT's goal is to help relax that pelvic floor and decrease the tone and decrease those trigger points internally. So they always explain to patients, they do both external and internal work. Patients sometimes get nervous about internal. So I always tell them, hey, talk to your PT. Maybe starting externally can help release internally. And then if needed, then internal can happen later once you're comfortable with that. But always have that conversation with your PT with your comfort level. And then I always tell them too that your PTs will teach you to use some tools. Sometimes a pelvic wand can be helpful that you guys can teach them to use. So they can do some internal work there. And then we also incorporate cognitive behavioral therapy and nutrition as well, because we want to look at the patient as a whole and not just treat their symptoms. That way, there's a lot of contributors to pain because it's a very complex multifactorial system. So we want to make sure that we're addressing all components of pain. So even though your pain might be in the hip, you really want to treat the patient holistically. So that way they have long-lasting relief.
Yes, excellent. I wonder, we're going to talk about the labrum in a minute, but Ginger, with the hip, I know like for when patients go and they have, say, back x-rays or back MRIs, and they find like, you know, the littlest thing, and then they're like, that's it, that's my source of pain. When you're looking at an imaging for the hip, is it sort of like the same thing that the imaging is not necessarily reflective of the pain driver?
Yeah, I think that's a very true statement, Sally, because rarely is, and I know we're going to approach the topic of a hip labral tear in a minute, but that's not typically the actual driver of the problem. There are other things happening. And although in hip arthroscopy, the seal and the labrum can be repaired, and certainly that can help preserve the hip and avoid a joint replacement in the future. There are so many tissue issues surrounding it. I try to carefully describe to patients, and citing studies in the past on when someone looks at low back pain and they've gotten diagnostic tests done, and looking at those studies that have kind of debunked that myth of being able to point to something and say it's DDD, it's degenerative disc disease or joint disease, and saying that's the cause of the pain, because we know in the literature it doesn't support that, which is a plus for people when they come in with someone who may have created a little unnecessary fear from a diagnostic test and told them that that was the source of their pain. We can kind of set the record straight and say, no, not necessarily. And that's a good thing, which means you can have osteoarthritis, you can have degenerative joint or disc disease And you can also potentially be pain-free or manage it so well that you can do anything that you want and it's not limiting. And I think the hip is the same, because although, again, the hip labrum can be an issue along with impingement, plenty of people are walking around with hip labral tears, and I do see patients all the time, weekly, in my practice, that are opting not to have surgery, and we're doing everything to conservatively manage it, and it's going well. So they have multiple options in front of them, that they don't have to become their diagnostic tests.
Yes, I think that's very, very important to recognize. I'm trying to bring up this, if I can find it, this video of the labrum. I'm not sure I'll be able to find it. But Amy, do you want to explain to everybody what a hip labrum is?
Sure. So the hip labrum, it's basically like a cover that covers the hip joint and it protects it. So I would actually think of it as more of like a positive thing. I know a lot of people, when they think of the hip labrum, all they think of, oh, well, there's, a tear, but it's actually a positive because it helps with the movement of the hip to make things smooth. There's synovial fluid so that the hip can move well. And then what
I don't know if you can see, I finally found what I was looking for.
yeah, a shock absorber, joint lubricant, pressure. It distributes pressure and it helps stability. Yes. And then when Dr. Marjorie was doing that hip rotation, that's basically helping the like lubricate the joint, helping the mobility of the joint. And things can go, labral tears are fairly common, but the positive thing is that there's so many things you could do to help if there is a labral tear, where you sometimes part of the capsule is too tight in a certain area. So as a physical therapist, we can help mobilize the capsule. There's things you could do on your own to help mobilize a capsule. And that helps just mobilize the joint in general. There's certain stretches. Some people respond well to stretching. Some people respond better to some massage techniques that they can do with their physical therapist or on their own. And then also there's injections that can be helpful if there's a lot of inflammation or nerve irritation. And some, yes, are more pelvic floor related, but some can go directly into the hip if that's a source of pain. It can also be diagnostic as well, some of the injections. So that could be helpful for a patient. Is my hip pain coming from my actual hip, or is it coming from my pelvic floor? And it can be confusing. It's not the easiest answer, but sometimes these diagnostic blocks can help differentially diagnose where that pain is coming from. So
Dr. Marjorie, do you like, how can you tell if the hip labrum, like patients they love to come in and go, because they see that MRI that they finally get and they go, I have a labrum tear. And in fact, I don't know if you remember this, Amy, at the first endometriosis summit, we had to ask somebody to leave because she went to the mic every single time, no matter what we were talking about, and asked about and said, but I have a labral tear. And so how can you tell if that labral tear is generating pain versus just being part of what goes on in your body?
Part of it is history, I think. So part of it is how functional are they? If they are someone who, like, first steps of the day, anterior hip pain, anterior hip joint pain, that's what they're complaining of, can't do like high impact activities, and that is what their function is, then I think maybe more that it could be a pain generator. And then of course the physical exam, when you bring them into flexion and internal rotation or fadir, does that reproduce their, so if they have a labral tear, yes, that is going to cause some pain in the anterior hip joint, but also is it worsening their symptoms when you do that?
because you're aggravating it. That's one thing. And then finally, also diagnostically, someone, I forget who, Dr. Amy Stein, a diagnostic injection that can be helpful too. Because if you do your internal exam, I'm going to guess most of the time, there will be hypertonicity in the pelvic floor, including obturator internus. But if you do the hip joint intra-articular joint injection, and that gets rid of not just the hip pain, but also their other symptoms, then you know that the hip joint is the pain generator.
Are we still seeing hip labrums that are torn from the gynecological stirrups during surgery, or especially the PTs? Are you guys still seeing that?
Mm-hmm.
Yeah.
Yeah.
I was discussing it on Instagram last week, and I see it much more with the fertility stirrups. They have, for some reason, the IVF guys have less education on how you're going to rip our labrums apart than the surgeons. At least the OR staff now tries to keep those stirrups in 30 degrees, but
Also,
yeah.
with delivery too, it can happen because of some either physicians or patients, they really pull their hips back to help with the delivery, or certain positions that can aggravate the hip joint. But
Now, what do we think? We talked about we have a very interesting week, because we did appendix last week. Then we have hip this week. Next week, I think we have bladder, and then we have groin. So they're kind of 4 webinars that all go together. How might the appendix contribute to some hip pain with referral pain? Do you see that, Dr. Sandra?
I haven't seen too much of that, to be honest. A lot of the endo patients that I've seen, they've undergone excision, and if they had endo on their appendix, the appendix has been removed.
Yeah.
That's a lot of what I've seen.
Do you see it, Amy? Yeah.
Go
ahead.
seen it more from a fascial connection. So the connective tissue that goes into the hip area, into the iliopsoas, as Ginger pointed out. So that's more of what I see. That, and if there was endo, if there is or was any scar tissue, it can be pulling on the hip joint.
Yeah, and go ahead,
A bit of
Ginger.
a unicorn. I have a bit of a unicorn story on the appendix thing. Because I actually had a labral tear from my 3rd birth, from a little bit too much enthusiasm with assisting my right leg. And it wasn't too long around that time frame, because most of the time we're having our kids, 2, 3, 4 years apart, whatnot. Anyway, that I had a second appendix removal. So, yeah, which was not biopsied for endo.
Oh, we're gonna get to your story in a moment, but I am shocked no pathology on that.
Mm-hmm.
Yeah,
Yeah.
very interesting.
So lots of connections there between, the appendix, the psoas, like Amy said, with the fascial connections. And then, of course, the hip labral tear, and having mechanical symptoms, from a hip labral tear, but also having the strange appendix connection too.
Now, Ginger was recently diagnosed, I think, by our favorite guy, Dr. Cernovo, down in Atlanta. And I'm curious, you treated yourself for hip pain and went for treatment for hip pain. How did that turn out to interplay with almost hiding your endometriosis from you?
It is a fascinating and also a little terrifying story, because I'm just really thankful that I had the background in functional integrative lifestyle medicine and pelvic PT, because I was able to manage it. I think that sometimes I know I'd probably be, quite disabled without that. But because of that overlap of having multiple issues that happened all at one time within a 10-year time frame, where there were valid things found, it's not like the surgeon was wrong. There was a valid, issue, but it wasn't all. They didn't also all necessarily always follow all the way through, like they should have, because they weren't trained in identifying it, and it wasn't biopsied. And so I ended up having multiple surgeries along fascial planes with adhesions taken down and things removed, multiple things removed that were never properly biopsied, in the midst of actually having a hip arthroscopy, all on the same side.
Mm. Very, very, very interesting. I also think it's interesting to do hip arthroscopy and break fascial planes with somebody with endometriosis, because you have the possibility of iatrogenic spread, which, for those that know my story, that's how I ended up with abdominal wall endometriosis. And do you feel like that contributed to the extensiveness of your endo when you were finally diagnosed?
I do. I feel pretty strongly about that. There was, implications from whether this was a second appendix issue or not. I mean, we'll never know the truth about that, but there was, implications of some contamination there, which I ended up with more adhesions, which were respiratory in nature, and connecting the liver and the respiratory diaphragm, which absolutely gave me all the fascial plane issues that I could ever want. But then the deep lesions ended up being on the left side. So it really was like dissection from the respiratory diaphragm all the way down, because it was bowel endo.
Yeah. Now, when you think, Dr. Marjorie, when you evaluate someone for left hip pain versus for right hip pain, are the differentials any different? Are you thinking about different things from one side to the other? Oh God, look at the look on your face.
That's okay.
I stumped you.
No, that's okay. To be honest, I don't. With women with endo, high suspicion or known endo, sometimes even just doing the fadir, so bringing them to flexion and internal rotation, is enough to flare them up. So it's confusing to see if that's true anterior hip joint pain, or if it's just their lower abdominal, like pelvic pain from the endo. That gets confusing. But I haven't, to be honest, haven't really thought about like maybe if it's like, diverticulitis versus appendicitis. I haven't really thought about that.
And what role, and this is for anyone, we don't talk a lot about pelvic congestion in terms of the endometriosis summit, but when we took a look at those excellent illustrations from Pelvic Global Academy, you could see how closely related to the nerves and the muscles the venous supply system is. How might pelvic congestion play a role into sort of that like anterior hip pain, bogginess, and are you seeing any of that? Go ahead. Who puts their hand up first? Yes, go ahead.
Definitely seeing that. I do want to add too that sometimes if there's bowel irritation on either side, you do have to rule that out too, just from the compression. If there's irritation at like the IC valve on the right, or the descending colon, or the rectum on the left. So that's something to consider. And then with regard to pelvic congestion, just having more fluid in that area can cause the feeling of fullness. Pelvic congestion, they do say like it gets worse with more standing and throughout the day. So there are things that can help it, like compression garments can really be helpful. And that's something you could also talk to the patient about. Does it get better when you just lie down for a while? Is it better in the morning versus later in the day? So definitely some things that to consider, because that it can be a contributor. Also, any like venous varicosities. We didn't even talk about hernias. I know you're doing a whole groin.
Oh, we might segue, but we have a whole hour in that.
I know, but you have to consider that.
I know.
One of the things
I
that
tried. So go ahead.
Oh, one of the things, just a brief comment I was going to make. I had seen someone recently who is very well trained also in pelvic PT, I saw this particular individual because she had chronic laryngitis, hoarseness, and vocal problems, and it was related to that, just that chronic pelvic congestion issue that we were trying to get a hold of. But it ended up that we worked a lot on the respiratory diaphragm in order to relieve some of those symptoms and improve her vocal quality, because your voice is everything, especially when you're a provider.
Yeah, I think a lot of people out there, even some providers I've seen, don't always know the difference between hip pain and groin pain. Dr. Sandra, do you want to try to like briefly describe the difference? I know we don't necessarily have the models to point to people on it, but I think like so many people go, my hip hurts, and then they're grabbing the inside of their thigh, and I'm like, it's not exactly hip. You want to just discuss the difference a little bit?
So groin is more kind of, we talk about like the inguinal ligament kind of from the hip to the pubic bone area. That area is kind of what we consider the hip area, as well as the inner thigh. So groin pain can come from, so we have our adductor muscles that insert to the pubic bone, and then you have your rectus abdominis as well. So sometimes that groin pain can come from what we call sports hernias, if there's any disruption in that area. Also from tight adductors itself, which is usually a compensatory pattern that can create groin pain as well. So it's a little bit different kind of pain source generators from what we would consider all the way up in the hip.
Yeah, I think also a lot of people, this is the other thing that I get, and it goes both ways to think about it. I think that people spend years trying to be diagnosed with endometriosis, and you've been minimized and gaslit, and it's trauma with a capital T, in my opinion. And then you're diagnosed and you think that every pain you have is related to the endometriosis, but the other side of it is that a lot of your pain is related to the endometriosis. In terms of hip pain, of course, endometriomas could catch themselves on the nerve and cause some referred pain into the hip, as well as endometriosis on the uterosacral ligament, or even significant posterior adenomyosis on the nerve chain. But how do you work with somebody to tease out the difference between whether or not the pain is coming from endometriosis or if the pain is being generated by the hip? I'm going to sort of give multiple shots at this, but Dr. Marjorie, I wonder how you do that.
I think hip joint versus endometriosis pain. So weight bearing, that's the biggest thing. Are they having more pain when they're doing more weight bearing activities and high impact activities specifically? So like walking, running, but like jumping, things like that, they can't tolerate. That tells me more it's hip joint versus endometriosis. And like endometriosis pain, sometimes it just comes about with any activity, any physical activity. So if they have just increased pain with any kind of exercise, even if it's not weight bearing, that tells me more endo versus hip joint. That's the easiest answer.
Right. Ginger, how would you answer the question, since we're all going to answer this question now?
Yeah. Well, I mean, evaluating people every day on it, and then having personally experienced what that feels like, and the distinct difference, having had that scope was, and the literature supports that too, is mechanical symptoms: popping, clicking, catching, at the hitch in their giddy up. They can't make it around the grocery store, and they also have usually a stride length difference on one side versus the other, where I will do slow-mo, assessment of their gait, and also ask them a lot of functional questions. Like Dr. Marjorie, I use the windshield wipers that you did in the beginning. I use that all the time as a functional test, because you can see all kinds of things, like how quickly and how far the femur may move on one side before the ilium is gonna drag too soon, too early, and then drag the whole lumbar spine with it and create pain. So I look for all those mechanical symptoms with the hip that are really classic to destabilization or micro instability in the hip, versus then asking them and breaking down the whole pelvic and endo side and going, okay, GI pain, night pain, cyclical, menstrual cycle, type pain, pain with respiration. And then I start to tease it apart because sometimes they do go together. Sometimes they have valid endo respiratory pain that's also connected to that really tight psoas that's compressing, across the front of the labrum. But it usually is not too difficult to tease those two apart.
Dr. Sandra, how would you tease the two apart? It's hard because I know you and Dr. Marjorie work like this together.
I know. Well, with endo, I mean, sometimes symptoms can occur during menses. They may feel hip pain more during menses than any other time, but sometimes they might always have pain in the hip, even though it could be endo related from pelvic floor connections to the hip. But if it's truly coming from, like, I agree with Dr. Mamsong, it would be more weight bearing, maybe activity related. Some of our endo patients are also athletes. So they have a long history of running, cycling, any kind of sports, will cause repetitive use in the hips that can lead to true hip pathology. That's where our physical examination really helps us determine, is it coming from the hip, like Dr. Mamsong mentioned before, that Fader test, or is it coming from the SI joint? So we're palpating the whole hip area, or is it their trochanteric bursa is inflamed, or so we're doing that whole exam. Is it a tight IT band? So that's how we kind of determine. Really, the physical exam helps us a lot determining if it's truly from the hip or is it more endo affecting the pelvic floor and other areas.
Amy, how do you like to chat with a patient to try to convey that you can have pain from endometriosis and you can also have pain from multiple sources? What's something, especially regarding hip pain, how do you like to approach that discussion with a patient?
That's a good question. I definitely talk about that there commonly is multiple pain generators. And as a PT, doing all the things that the three of you already mentioned, but also doing palpation with the patient and seeing, like, okay, is this a psoas that's causing some of the endometriosis pain or the hip pain? Or is it, or could it be endometriosis? Not always easy to determine, even through palpation, but you get a good sense. And also, if you do certain tests that the three of you already mentioned, and it coincides with what you're finding with your hands, then that's a good indicator as well. I also wanted to add to the whole differential diagnosis that I've seen commonly when I palpate internally, right onto the obturator internus, they say, oh, that's my hip pain. So that's a good indicator too of whether it's endo versus a hip dysfunction versus an irritated obturator internus or pudendal nerve that could be a contributor of pain. We see that a lot, where they that like groin type hip pain can be directly from the obturator internus. But again, is there endo in the area that's contributing and causing some restrictions and irritation to that area too? So
We're of course leaving out my favorite nerve discussions, which is ilioinguinal and genital femoral, and the role of those, because that we'd be here for 6 hours if we added those discussions. And that we do have to, there is a second piece to groin pain because it's really hip and groin pain. So the good news is, if you were excited by this particular discussion, that we have close to like 3.5 hours on hip and groin pain at the Endometriosis Summit, and it's open mic. So I'm hoping that during the commentary time that Ginger will get up and share with us her expertise. But the team of Dr. Sandra and Dr. Marjorie have helped arrange the groinecology lab, but which is open to practitioners as well as any attendee of the Endometriosis Summit. But in terms of the didactics, we have an entire program that's going to include everything from vulvar pain with Amy Stein to groin pain, to why all your hernias are being missed on MRIs, to a discussion on the pelvic nerves. And I'm also going to dance around in some hernia leggings. It's going to be very exciting. I remembered to put them in the box that's being sent to Florida already. It's great. So the Endo Summit's coming up. We end each webinar by asking the same question. Dr. Sandra, what are you looking forward to at the Endometriosis Summit?
Connecting with my peers is the most exciting part of it all. Definitely, first and foremost. I'm looking forward to seeing you guys in person. I know, Amy, we did a panel last year together, so that was fun. So looking forward to working with everyone again and seeing everyone again, and just building up on knowledge, helping our patients and getting them better.
Awesome. And Ginger, this will be your first Endo Summit post-diagnosis, I think. So what are you looking forward to? And not your last, because we've got to talk about the voice for 2025. But what are you looking forward to about the Endometriosis Summit?
Seeing the collective energy of hope and how things are evolving and transitioning. And I know that, all of us have been doing this for, a long time, decades. And so I love to see that energy of inspiration and motivation and everybody out there working towards the same end, which is ending, for me, it's being very passionate about ending that medical gaslighting and having people get the help they need as soon as they can. So I just love that energy.
That's fabulous. And Dr. Marjorie, what are you looking forward to? You guys have a short drive in Florida.
We do. I'm with Sandra on this one. I think it's connecting with my peers, connecting with you all. It's an honor, truly and honestly, to be in this panel with the Pelvic OG. So I'm looking forward to meeting you all in person.
Yeah, we're excited. And Amy, who has chosen to celebrate her big birthday at the Endometriosis Summit, chosen or was manipulated into it. I don't know which one. What are you looking forward to at the Endometriosis Summit?
Besides Margaritaville?
Margaritaville. Yes.
I'm always like all of you, always learning new things. I feel like single time I go, I learn new things. Also, what the latest is, Sally recently had Dr. Salgado come to New York City, and he talked all about the ultrasound diagnosis and the differential diagnosis with the ultrasound imaging. So it's always something new and it's exciting. And I agree with getting together to give hope to people. That's really rewarding.
I think this is wonderful. I think it's just, we are hosting the Endometriosis Summit March 8th through the 10th. You can watch in Orlando in person, or you can watch virtually from anywhere in the world. The virtual component comes with a recording for 90 days. If you're looking for tickets, you can log on www.theendometriosissummit.com. And it should be fabulous. I am looking forward to, if many of you have not noticed, we are usually a duo on Monday nights, and Dr. Vidali has been in the OR almost every Monday and hasn't been able to join me once. So I think when we get to the summit, it'll be nice to have the whole team back, to have the crew back together. Yes. And I will see you online next week. I think we are talking about bladder. And I think we have some amazing people joining us, but I don't remember who yet. And I will see you all then. Take care, everybody. Good night.
Thank you guys. Bye.
Thank you. Bye.